Hi, everyone. This is Kathi Bush, and welcome to the DandleLION Medical webinar titled The Neuro-NICU Trend and Expanding Roles for Every Bedside Provider. Our faculty presenter this morning is Kathi Randall. Kathi's been involved in neonatal ICUs in many roles over the last 25 years, including a CNS, nurse practitioner, educator, and bedside nurse. She is the founder of Synapse Care Solutions, an education and consulting company dedicated to supporting neonatal neurocritical care units through consultation, in-person workshops, online courses, and an annual nurses conference. Kathi's been helping hospitals implement bedside AEEG brain monitoring into the NICU for more than a decade. And over the last 5 years, she's been spending her time with the Neuro-NICU team at Stanford University and traveling the globe supporting Neuro-NICU programs throughout the US, Thailand, Lebanon, Oman, and Brazil. She's a frequently invited speaker at international conferences with a focus on educating others on the use of AEEG, therapeutic hypothermia for HIE, and creating neuro-nurturing NICUs. So with that great introduction, welcome Kathi, and we're excited to hear your presentation this morning.
Thank you, Kathi Bush, and thanks for allowing me to present one of my favorite topics. And I often are here. I'm here at the webinars, you know, in the behind the scenes, but this time I'm here with you guys speaking. So it's kind of a fun switch for me too. So let's just get started. And as Kathi said, I spend my time now traveling around, and I guess here are some of my disclosures. Other than my own time, no one paid me to do this presentation. And our objectives for today are to list the 4 pillars of the Neuro-NICU practice framework and to describe 2 daily practices, QI opportunities that you can do as bedside providers that will influence one of the pillars of care that we're going to talk about. So as Kathi said, I've spent many, many years in the NICU now, and I live in Southern California and commute up to San Francisco area to work with the team at Lucile Packard in their Neuro-NICU and continue to do that about once a month now. But one of my favorite things to do is really to travel and to meet with nurses and other bedside providers in other parts of the world as well who are implementing similar neuro-NICU frameworks in their units. And this is me with a group of nurses. We just finished cooling training in Lebanon, in Beirut at the American University there, and it was just such a fun time to be with them and to see their passion for what they do. Just like all of us here in the States, it's sometimes hard to think about these NICUs in other parts of the world and what they're doing. As Kathi mentioned, I've spent some time in Thailand helping them as well. This was an AEEG workshop we did. Had a little detour and got kissed by an elephant, which was amazing. And then for the last few years, including coming up in 2019, I'll be going back to Sao Paulo to help with the Neuro-NICU team there. And they're doing some amazing things, reaching out throughout their country, really spreading this neuroprotective framework of care throughout the country. And as you know, Brazil is a very large country and has, as you can see here, some mountains, and it's very rugged. We think we have a hard time with transport. You can really imagine in some of these remote places of these other countries how transportation is really a limitation to the care people can provide, and how they have to have everyone everywhere trained to do some of these things, whereas here we have the ability to transport more quickly. And so anyways, it's a really fun place that my life has taken me, but you know, I'm excited to be here just to share a little bit more with you, and maybe to make it a little more practical and find ways that you can implement some of these things that other places are doing. So I thought we would start with just some basic definitions around what is a neuro-NICU so that we can all be on the same page. And so if you look at the word neuro-NICU, here we have neuro space NICU, but I want you to really think about that every NICU is a neuro-NICU. And whether or not you call yourself a neuro-NICU, you are taking care of baby brains that are developing every single day. And so if we think about that very premature infant brain being like a mushroom, really impressionable and easy to injure, and that we need to develop that into a robust, developed, really convoluted cauliflower, there's so much growth that has to happen. And so no matter if you have a NeuroNICU or not, you're impacting a baby's brain every single day. And so I just would like to turn those words around, and instead of calling it a NeuroNICU, we could just call every NICU a neuron ICU, because those neurons are growing at such a rapid rate. And so I hope that you will agree that pretty much every NICU is a NeuroNICU. But there are some centers that have been really leading out in this area. I want to highlight and congratulate the team at UC San Francisco, who just celebrated their 10th year anniversary of their NeuroNICU just last week. And this is a picture of their early team working there. And many of these people are still on their team. And there are other units, and this is by no means an exhaustive list, because I know there are new NeuroNICUs popping up everywhere, but these are some of the centers that I'm aware of that I've worked either directly with or visited. And so there really are many, many units doing this work in a very systematic way. But again, all of us really are NeuroNICUs. So why is this trend evolving? And so we'll spend a few minutes on this, and then we'll really dive into what is a NeuroNICU and things that you can do every day. So really there's this recognition of improved survival, but at the same time, increasing rates of morbidity, or at least stable numbers of morbidities. And so with brain injury specifically, we know there are so many different causes and diagnoses and reasons why infants have brain injury, and that those outcomes depend on the location of that injury. As you see in the middle there, the MRI with that white shiny spot on the right-hand side of the image there. So the location, the extent of that injury, is it isolated or is it diffuse? And if you look at the left, during those critical periods of brain development, the timing of injury, when does it happen? Is it a primary neuralization problem? So is it a neural tube defect? Is it actually an issue with nutrition that then impacts neuronal proliferation or migration? Or is it prematurity that then exposes a baby's brain to noxious stimuli and kind of derails that normal maturation pattern and organization and migration that might happen? Maybe a baby who gets septic, and then, you know, that inflammatory pathway and process that's happening disrupts that normal migrational and organizational and even myelination problems, and resulting in things that we see like with sensory issues and CP. And then of course, intervention. So outcomes depend on the interventions we provide and whether or not we provide those interventions that are in a timely way. So this cute picture of this dog, we'll see him again, but things like brain cooling and being able to provide brain cooling to infants as early as possible after we've identified them as eligible for hypothermia. So whether or not we can provide the intervention is one thing, and whether or not we have the knowledge and skills and equipment to do that, but at the same time, do we provide it when it matters the most? So we'll talk about some of those as we move into some of the neuroprotective strategies that many NeuroNICUs are using. So one of the things we know, and as I mentioned, is that the incidence of disability really has not decreased in decades. We still see CP, we still see significant cognitive impairment, epilepsy, and both term and preterm infants are affected. And we'll talk a little bit about some of the differences between those groups. So if we think about our preterm infants and we look at this study, and this came out of Epicure from the UK, when they were looking at infants at 26 years of age who were born preterm or low birth weight, and then compared them to term controls. And what they found in this study was that even at 26 years, that premature and low birth weight infants had a significant difference in their IQ, whether that was verbal, performance, motor, full scale IQ. Preterm infants, the experience of being born preterm lingers for a lifetime. One of the other areas that I think we're learning more and more about are the psychological and mental health disorders associated with prematurity. And I won't go through this slide in too much detail, but just to show that the blue lines are the preterm babies and the red lines are the term babies. Again, in the Epicure study, looking at things like attention deficit, conduct, emotional disturbances, autistic spectrum disorder, autistic-like behaviors, and finding that these psych disorders, both internalizing depressive situations as well as anxiety and stress disorders, are more prevalent in our preterm babies. These particular results are for the prevalence of psych disorders at 12 years of age. So again, this experience of being a preterm infant then lasting, for years and years to come. Again, busy slide, but just to say that there is an increased distribution of autistic-like behaviors in our preterms. Those are the kind of green levels or lines there, and just showing a 6 times more, 6 times more likely to have these autistic-like behaviors at schoolroom age, so 6, 7, 8 years old. So 6 times, that's a 600% difference. And just again, it's not autism, but it's more autistic-like behaviors. And those are not things we see on ultrasound or MRI. And when I look back at some of the evidence of looking at long-term outcomes, I love this letter to the editor that Dr. Levine wrote back in 1981. And he said, on the basis of our follow-up data, we feel that the size of the hemorrhage on ultrasound is by no means the only guideline to outcome. So in the 80s, you can imagine that the ultrasounds were not that great, right? But that they knew that the hemorrhage, although we were very concerned and continue to be concerned about IVH, that it didn't tell the whole story. That there were kids who had grade 4s who had great outcomes and kids with no hemorrhage who had bad outcomes. And they said that there may be other factors influencing these roles. We're almost 40 years, we have much different imaging, but we still can't accurately predict every kid who's going to have an issue. And none of this imaging really can give us a clue onto who's going to have those psychological disorders. Those are things not seen, but that are not minor to the family as we go through life. And Dr. Milgram out of Canada said, neither the structural brain alterations nor the medical complications common in the NICU fully explain the variation in long-term neurobehavioral development. This was, again, almost 30 years after what Dr. Levine said. And so we know that there's something that's happening to the infant who finds themselves in the NICU that changes the way their brain is developed. And this is why we need to think of ourselves as neuron ICUs. We're really caring for this developing brain. So we recognize that we have this improved survival, but that we still have increasing morbidities. But a neuro-NICU is really also about translation of research into practice. And so I'm going to give several examples of that and showcase some case examples and centers of excellence who are doing some really cool things around that. But neuro-NICU, I mean, we've been studying the brain and trying to create all of this, better environments for us. And so we've been studying it. Now it's time for the places where we now have evidence, it's time to translate that. And so I think that's one of the exciting things about what a neuro-NICU does. And then, of course, the outcomes that these infants and their families have, so things like psychological disorders or CP or seizures, these are things that we, of course, always want to improve. And so by kind of shining a light on the brain, we can then begin to improve those short and long-term outcomes. And so everything we do pretty much impacts the brain, so we want to make sure that we shine a light there. So one of the other things about follow-up that I think is so important is this is an interesting study that came out in 2016 showing that at 6 years old, approximately 2 out of 5 infants who were diagnosed with severe disabilities at 30 months, so 2.5 years, no longer had severe disability. But in contrast, 1 in 4 infants without disability at 2.5 were found to have moderate or severe disability at 6. So these kids need long-term follow-up. These at-risk children need long-term follow-up because the kids who are doing poorly in the beginning turn around and do better later, whether that's nurture, nature, environment, nutrition, whatever that is. And that there are some infants who were doing well earlier on who seem to then have an issue later, whether it's cognitive issues, behavioral issues. And so we may be looking for some things when they're younger and some things when they're older. But it's a little bit of a moving target. And again, we don't have very good we don't have a crystal ball, and we don't have a really good way to predict who these kids will be. This is why we need to continue to follow them. And here in the United States, our ability to do good long-term follow-up, I mean, I know in my state in California, 0 to 3, and if you're not significantly delayed at 3, you better believe you're out of the programs. But you can see that some of these things happen at 6, happen at 11, and still linger at 26. And so we don't have a structure that really supports this well. And so we have to lean on our families to be aware, to give them anticipatory guidance, to know to be on the lookout, not to frighten them, but to be sure that they know that some of these things might show up later. And that if they have a little inkling about something being off, or if they have other kids and things aren't matching up and they can see the differences, to not discount the fact that it could be the NICU stay and some of their other lingering morbidities. So when we think then about the Neuro-NICU and translating this research into practice, I like to keep things kind of simple and put them into these 4 pillars. So we want to talk about neuroassessment, neuromonitoring, neuroprotection, and neurodevelopment. So first off is neuroassessment. This is something that we all do regardless of our role in the NICU. We assess our infants daily and sometimes multiple times per day. And if we think about that, we're really looking for very specific things. And one of the quotes I love from Florence Nightingale, and I modified it a bit and included all of us, but she says that the most important practical lesson that can be given to a nurse, and I insert to any bedside provider, is to teach them what to observe and how to observe. So remember, Florence Nightingale practiced in the 1800s. And what she really meant about this was which symptoms indicate improvement for the patient, or the reverse, a worsening of a condition. Which things are important and which things are not important, right? So not everything is telling, but we want to keep an eye on almost everything. Which things are evidence of some sort of neglect, and then what kind of neglect? Is it stimulation neglect? Is it isolation, neglect? Is it sensory neglect? Is it actual physical, nutritional neglect, emotional neglect? What kind of neglect is that? She knew that these things, being able to identify these things, were important for the outcomes of patients, even in the 1800s. So for us in the NICU, we want to provide great clinical assessment, and using our clinical assessment skills cannot be replaced by a tool. There is still something about that interaction of you and the patient that is really important, but we also know that doing these clinical assessments is very challenging, and that it's influenced by the baby, mostly by their gestation, by their state of wellness or illness, their acuity, medications they've received. They're oftentimes covered with lots of equipment. But number 1 on the list is really our experience level. There's so many different people who are working with us who have different levels of experience. They maybe are new to the NICU, or maybe they transitioned from another population into the NICU. We have, learning physicians, new therapists. We have new people coming into the NICU all the time. And so our experience we bring, maybe 5 years, 10 years, 20 years, versus someone who has 5 to 10 weeks of experience, it's just different. And so this is where the tools that we have can really be helpful and help us to have a more common language. And so this is where standardized exams come in. And there's just no way that I can go through all the different kinds of exams, and there are more and more, I think, every day. But I listed out a few of the ones that I think are probably the most common. So we use the SARNOT exam, which is a assessment of neonatal encephalopathy, can be used to help screen babies for HIE. There are other tools that are out there, but I think SARNOT is used most now currently, and was used primarily in all of the research that was done for cooling babies. Of course, we have pain scores. We have an ever-evolving tool set for NAS babies. So of course, the Finnegan being one that we've all used for many years. And if you heard Dr. Berkowitz speak a few months ago here on a DandleLION webinar, he's kind of more in the functional assessment of babies with NAS. Can they eat? Can they sleep? Can they be consoled? So, moving from kind of a checklist approach to a more functional approach. And I'm sure there will be others as well. I just saw an article yesterday that was, should we even be applying these scoring tools to premature infants? So 35-weekers who come in who have exposure and find themselves in the NICU, is this tool appropriate for them? They don't score out on some of the other things like the digestive issues and sleep disturbances. So they score low on Finnegan, but does that mean that they're not having withdrawal? And maybe one of the functional assessments might be better for them. Of course, especially the therapists in the audience, we use so many different tools, and your group continues to develop them and to perfect them and to be so competent at using them. Most of us who've been practicing nursing for a while are familiar with the Dubowitz exam. I don't see it being used as much anymore. It's used in Europe still a fair amount. But we can look at that as neuromuscular and neurobehavioral development, doing the Dubowitz. There are other tools like NIDCAP, APIB, MBAS, and so many more. I can't even begin to list them all, that really help us to evaluate an infant's behavioral state, adaptation to the environment, response to the environment, all of them providing us with a way that we can speak about the infant in a common way. And of course, I think just looking at the baby, right? And the picture like this tells 1,000 words. And we can, most of us, if we've been in the NICU even for a short amount of time, can look at this baby and know that he's telling us something. We can see that hand that's splayed. We can see that eyebrow being furrowed, the eyes being closed and shut down, the mouth being lax. We can see that he's using all that energy to kind of press away whatever is bothering him with those arms extended. So looking and observing is still one of, I think, the most powerful things we can do for our babies. So in addition to physical clinical assessments, we rely on tools. And I talked already a little bit about some of the imaging and why imaging is so important. But when we think about providing for this imaging, there are some roles that all of us can play in making that a safer, more nurturing experience. So things that we can do, no matter what your role is helping to keep infants positioned and warm and to restrict their exposure to noise. Temperature management, so asking someone to warm an ultrasound gel before they put it on the infant. Helping to provide a neutral thermal environment with either extra blankets or asking someone to not open the hood of an omnibed or an incubator. Don't put the wall all the way down. Please, will you do that through the portholes? And then, of course, minimizing the use of sedation, mostly for MRIs when we need to take our bigger babies down, and using some of the techniques that we have for that. So there are so many ways that all of us, regardless of our role, if you're a nurse practitioner and you've ordered that bedside ultrasound and you can be that second pair of hands, or a therapist or a developmental specialist who sees a baby who's having that done and, just offering that comforting touch during that time, we can play a role in all of this. We can be sure that the person who's taking that baby to the MRI knows how to use the tools that help them to be able to minimize the use of sedation. So one of my favorite tools to do that is this little swaddle and feed method. And some hospitals just swaddle and feed and wrap the kids and pack them down to go. But there are many devices like this Papoose device that works fantastic to helping to minimize movement, help babies feel very secure, and allow to get very quick, non-sedation-free MRI scans done. And especially as our sequences are getting longer, we need to really rely on these tools to help us to be successful and to not have to use so much medication. So there are two centers, they're listed here. The team from St. Louis, they have been some of the most common to publish in the literature around successful brain imaging for unsedated neonates. So you'll see here listed, the authors are Amit Mathur, Jeff Neal, Robert McKinstry, and Terry Inder, so when she was still at St. Louis. And this is a great overview of the why and the how of how to provide sedation-free MRI. There's also a trend, and I was recently in Boston, and there's actually in-unit MRI that's been installed there, the first in North America. There are others in other parts of the country or other parts of the world, but an in-unit MRI which allows them to do scans on babies up to 4 kilos. And their transit time to and back to, so from the bedside to the scanner and the scanner back to the bedside, 7 minutes tops. So I thought that was amazing to be able to provide that safety, be quick, keep them thermally stable by providing these in-unit MRIs, which I think are kind of cool. They're happening more and more. So pillar number 1 is all about assessment. And so we're really kind of continuing in on that, but I think one of the areas that many units add on is this bedside brain monitoring. And so when we think about bedside monitoring already, we monitor temperature, end-tidal CO2, pulse oxes, and saturations, respiratory rate, heart rate, blood pressure. But really, what about the brain? What about all of that physiology? How is it impacting the brain? And so bedside brain monitoring is really about getting above the clavicles when we're monitoring at the bedside. And so all the types of devices that are out there to monitor, again, an additional way to assess the brain, are either brain function or brain perfusion. So again, what's the functional status of the brain? Is it actually active as we would expect, or is it suppressed due to medications? And then again, that physiology, how is the physiology affecting perfusion to the brain? So not just looking at a pulse ox on a hand or a foot, but looking at the brain perfusion, the oxygenation of those end organs, those tissues of the brain. And so these bedside tools are becoming more and more popular. And as Kathi mentioned, I've been teaching about AEEG for a really long time now, but it's one of my favorite tools because it really is a bedside tool. And NIRS the same. I mean, NIRS is a little more complicated, but AEEG is 100% for us at the bedside any time of the day so that we can assess the quality of the brain and how it's doing. So what are some of the roles that we can take related to that? Sensor application is number 1. So you can't get anything about the brain done in this way with monitoring until you have sensors on. So sensor application is typically a role of the nurse, but it can be the role of a therapist. I've seen hospitals who use respiratory therapists to apply AEEG leads, to put on NIRS, just like they apply pulse oxes and manage, and that it's very much in alignment with their scope of practice. It can be anyone, physicians, nurse practitioners, fellows, all of them can have a role in sensor application. Once you have the sensors on, it's important that people are aware how to read the tracings and that they can troubleshoot problems. And so most important is impedance, because that's how well the stickers are sticking or the needles are attached to the baby. And so we want to make sure that they are in good alignment, that the sensors aren't touching. So if you come in as a therapist, maybe you're going to be doing some passive motion or some massage with an infant, and the baby has on AEEG, you want to be aware of where the sensors are. You want to be sure that, that as you're manipulating and moving the baby, that when you're putting the baby back together and tucking them in, that the sensors are and the wires are all in good spots. So just having an awareness that it's there, it's important for all of us who care for the baby. So making sure that the electrodes are not touching. Here's an example of them touching. This causes those to, to disrupt the signal and can make interpreting it really challenging. But it happens. These babies are in humidity and the sensors move around. So this is an example of, just assessing the impedance. There's this little cartoon head on the left-hand side, and that allows for us to see the quality of the signal contact, how well the electrodes are touching the skin. And depending on what brand of device you have, it may have different layouts, but almost all of them have some little picture of the baby's head and little spots that indicate the electrodes. So documentation of those sensor impedance is really important. And for all of us, no matter our roles of working with the baby, is marking clinical events that we might provide to the baby. So did we observe some sort of unusual movement? Did we actually provide hands-on care? Did we do massage? Did we transfer for skin to skin? Did we give a medication? So marking those clinical events are important for all of us. Here's an example of a place where medication was given. And you can see, even without really understanding how to read AEEG, if you can see my cursor, my little, what do you call it, pointer, you can see here that there's this very thick band kind of moving along. And on AEEG, this is 3.5 hours of compressed tracing. And you can see it's nice and thick, and that's normal for a baby this size. And then right here, the medication's given, and it just gets flat and low. Well, you don't have to know much about AEEG, except that I can just show you here. Here's the voltages: 0 meaning no brain activity, 5 microvolts, 10 microvolts, 25, and 100 are over on the left-hand side. Those are your scale for the brain activity. And if you can see, this AEEG goes almost down to 0. And you can see the time down here where the red line goes, it says 1732, and you have 1800. So that's 30 minutes between that red line and 1800. And that brain activity is very flat. So we can see in real time the effect of things we do. And by marking these events, these clinically significant events, it makes interpretation much more vivid and tells the story a little bit better. Maybe we're at the bedside and we notice that the mom is patting the baby. Pat, 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 pat. Very rhythmic and can be confused and looks like seizures, right? Because seizures are rhythmic patting or spiky things on EEG. And we can see here up at the top, we can see this spiky, 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 spiky stuff. And we could be faked out and think this baby's having a seizure. But in fact, someone had marked this event, number 17, and they had put on there that there was cares and patting. And so it allowed us to not be concerned that there was maybe these seizures that we weren't aware of. So documentation, regardless of your role, is very important for these. And if you have full EEG, very similar documentation is helpful. So if you see clinical seizures, if you give a medication, if you're doing hands-on cares, you can annotate that full video EEG. Don't be afraid of that. Don't be afraid to participate in that kind of monitoring and to really just, you know, help the person interpreting it know this the whole story. So other things that we can do are to trend and read the abnormal findings. So for bedside nurses especially, when we are talking about AEEG, I like to think of it as another vital sign. And just like I trend heart rate or trend blood pressure and would notify someone of abnormal findings or a change in the trend, I want to be aware of what's normal so that then I can identify that and report when things change. And so every hospital is a little different about how they do that. But it is definitely within the scope of nurses to understand those patterns. And then for therapists, I think it's important to know how to read the AEEG as well, because then you can actually choose when you might intervene with an infant. You can assess their sleep-wake cycling, and maybe you delay that intervention for a few minutes and you allow them to complete that non-REM cycle before we intervene, or we see that they're just 20 minutes in, maybe we'll give them 10 minutes to see if they kind of come out of that. So the AEEG can be used in a quite powerful way if we all kind of communicate and collaborate and share how to read them together. So there are many different tools out there. I've written a free ebook. There are, I love this, that Lauren created this layover tool where you can lay it over the AEEG, and it kind of has these, it's like a clear cellophane paper, and it has the borders for normal and abnormal, and help people to read that. The team at Brigham and Women's in Boston does an AEEG email strip a week. So if you're interested in improving your skills around AEEG, I love that they offer that. You can just Google it and you'll find their landing page to opt in for that. These are some examples of the normal. So I'm not going to spend time on this today, but just to say there are many resources to help you to be able to assess normal and abnormal. So third up in our pillars is neuroprotection. And these are really those things that we do that help to prevent cell injury and cell death. We use neuroprotection, the title of that, or that topic, neuroprotection, we apply it to everything. And for this talk, I'm going to separate neuroprotection from neurodevelopment, but know that they go hand in hand. But these interventions that I'm going to talk about are really about preventing cell death and injury. And Florence Nightingale would be the first to say, and I doubt she was the very first, but she did say, the very first requirement is in a hospital is that it should do the sick no harm. And I think even today in our NICUs, we do really believe this. The first job is to do no harm. And then it is to help them to recover. And so there are so many ways that we can provide neuroprotection. And so I want to think about this maybe in a little bit broader scope than you have before. So we're talking about preventing injury and cell death. Well, you are probably already doing most of these things. And maybe you haven't connected the dots back to the brain protection that you're providing. So preventing infection, preventing inflammation, preventing NEC, preventing IVH, all of these things are done to prevent injury to the brain. Yes, they have some primary outcomes as well, but in the end, all of these things, when they occur, CLABSI, infection, NEC, that inflammatory pathway, ventilator-acquired pneumonia, actually keeping kids on vent, there's ventilator-acquired brain injury, that inflammatory response to the body to infection or indwelling mechanical ventilation, those things cause injury to the brain. So the programs you've created to reduce incidence of other issues that happen in the NICU also impact the brain. I think most of us have some sort of IVH protocol, whether that's midline head positioning for 36 or for 72 hours for those first 3 days of life, whether it's for a week, whether it's using a tool or just using different bundles and wraps and things. We're all looking to prevent IVH or to reduce the rate of IVH in our nurseries. And there are many ways we can go about that. This is a great poster that was presented at a Gravens meeting a few years back now. It's from East Tennessee Children's Hospital, Knoxville. It was Building Better Baby Brains, the 4B Project, which was a nurse-driven IVH prevention initiative. And they had several different guidelines. I think there was a total of 10 on this particular poster that they outlined, 10 things that they did. There's a few here from the little picture I took. If you just Google, you'll find this poster online and you can look at it all. But things like admitting an infant to a bed space against a solid wall in a low traffic area to avoid and decrease noise and stress from NICU traffic. Reporting mean blood pressures that are lower than gestational age and intervening to intervene to prevent further blood pressure fluctuations. Number 3, maintain midline head position when lifting the infant or for procedures. So by doing this, and again, I think there are about 10 on this sheet, what they found is that when they compared themselves to themselves, 2015 to 2016, by doing these bedside interventions, they were able to drop their rate of IVH from 21% to 10%. And I know that a publication is coming out from the Netherlands very soon that's showing a very similar result after doing midline head positioning, some 2-person care, some diaper change, not lifting very high for diapering. So these very simple things can have a pretty dramatic effect. And so we want to make sure that we're keeping an eye on what other people are doing and finding ways that we can maybe implement these in our units as well. So we want to prevent those primary injuries, but we also want to reduce injury progression. And one of the things that we do the most is that brain cooling. And you've seen this picture of this cute dog before, but that's really what we're trying to do with cooling, is reduce injury progression. So the injuries occurred, the asphyxiating event has occurred, the brain has had the impact, and now we're going to try to reduce that injury progression. So when we're talking about infants undergoing cooling, there are a lot of things that we can do. So depending on your role in the unit, getting that equipment ready, making sure the staff are well trained, creating tools that improve documentation and communication. Our team at Stanford has worked really hard at this. We've created some handoff tools so that if someone goes on a break and someone's covering a cooling baby, that they know where they are. Are you in induction mode? Are we still working on getting the kid to target temp? Is the baby, how long have they been at target temp? Is the baby in maintenance mode? Are we within an hour or so of rewarming? Where are we and what's due and what should we be watching? So helping to have those tools. The team at Brigham and Women's, when I toured their cooling program, they have a great handoff tool as well. And they do, because they don't have cooling babies every day, like most of us, they want to make sure that the equipment is ready. And so they have a checklist. So just like a code cart check, somebody's checking to make sure all the cooling equipment is ready. And the other thing they're doing is to think and look about all the non-neurological effects of HIE. So we know that when we're taking care of these babies, that there are many things that are beyond just the brain that are happening during hypothermia. So watching the labs and assessing for other issues that may be coming up with renal failure and respiratory support. And then being vigilant for those clinical and subclinical seizures. Of course, using brain monitoring helps with that as well. Diane Wilson and her team at Sick Kids in Toronto have created a clinical care pathway for HIE and undergoing cooling. She shared that at PAS. She shared that in our brain cooling course. She's really helping to outline all the things that we can be doing. On day 1, here's the things that we should be doing. On day 2, here's the things we should be doing. On day 3, here's the things we should be doing. It's a fantastic care pathway, and she's really willing to share that. The other thing that we want to work on is really positioning. These infants undergoing cooling are typically ill. Some of them more mild than others, but we want to make sure that we're still paying good attention to comfort, that we're not allowing them to be in any kind of distress. We know that when they're in distress, that they're more at risk for continued brain injury, and providing cooling is all about minimizing progression of injury. We need to keep them calm. We need to provide them with comfort. Many units are now allowing families to hold babies who are undergoing cooling, not delaying that for 72 hours or longer. So what can we do to keep them comfortable, to keep them contained? Those are all things that no matter your role, you can be paying attention to. And those are especially our therapist colleagues helping us to, with all the equipment and the cooling mattress, providing that containment, because these babies, oftentimes the sicker they are, the lower tone they are, that they oftentimes look like this. Many places are using a morphine drip, other places doing intermittent. So providing some sedation if needed, not allowing infants to shiver, to keep them comfortable. If a baby shivers, they're increasing their metabolic rate. If they're increasing their metabolic rate, they're fighting against the treatment. The treatment is the temperature, and we have to keep them cool, and we need to keep them comfortable. So we want to make sure that we're managing all of that. And then finally, for these cooling babies, it's really about supporting parents through this as well, and helping them to acquire the parental role. So whether this is you're providing some good education to them and handouts about things to expect, especially if they're being transported from another hospital to your hospital to receive cooling, or maybe you're at the place that sends the baby, you're at the referral center, and those families need to understand why the baby's going and how the therapy works, why their baby needs it. So some great tools that are out there. Charlotte Parkinson is the Neuro-NICU coordinator at Johns Hopkins in Maryland. She has a parent education tool. She's more than willing to share it if you just email her. You can look her up online. She's listed under the program. But they've created an education tool. And so whether you use that one or make one of your own, it's really important to be thinking about this very stressful situation. Just like we do for our preemies, we need to think about it for our HIE kids too. If you haven't seen Dr. Alexa Craig's parent communication studies that she's done and published over the last year or so, she's a neurologist from Maine Med, and she's been investigating through qualitative research what are the communication breakdowns, what are the communication expectations that families have when their infant is undergoing cooling. There are some profound nuggets of truth in these articles, and I would highly recommend anyone read them if you provide cooling to your patients. Talking about the things we say, the things we don't say, the things that we forget to say, it is poignant and really inspiring to help us to know how to better care for these families. So, oops, after rewarming, I don't know why that picture is covering everything, but after rewarming, we need to watch on temperature. We need to reassess the neuro exam. And then the third thing here was just to shine a light on Kelly Andrazik, who's at Stanford, who's one of our OTs who helps to do all of our feeding evaluations on our HIE babies. And so she actually reviews them. She's working with them throughout cooling, but after they're rewarmed, if they're having any kind of issues, she's assessing them and then is part of their follow-up team. And she's finding quite a high number are rebounding back to clinic. And it's been a real fun project for her, where she's kind of, done some retrospective review of our babies over the last 3 to 5 years, and how many of them needed to leave with feeding assistance, feeding tubes, and who need long-term follow-up. So she should be publishing that shortly, but just another way to get involved in these other disciplines involved. So post-hemorrhagic hydrocephalus. So we talked about cooling and ways to eliminate or to minimize progression of injury, but post-hemorrhagic hydrocephalus is an area that I think we don't have a lot of standardization, and there's so much variability from hospital to hospital and even country to country on how we manage babies after they've had IVH and after, as they develop post-hemorrhagic hydrocephalus, if they do. So Dr. De Vries and the group in Netherlands has been looking at this, and they have just completed their study called the ELVIS trial. And I think it's a funny name, right? Easy to remember. The early versus late ventricular intervention study. And what she did is she had looked through her infants. It was a retrospective study. And she looked and tried to see if babies were intervened at this level, did they have, this kind of outcome? And if they were intervened later, did they have another kind of outcome? And so no one had done a prospective study to say, we believe, at least in the cohort she looked at, she thought that early intervention was better. But she wasn't sure, and she wanted to say what would be standard of care, and maybe what we should be doing is intervening earlier, and what would be the outcomes. And so there had never been a good trial to find out the best time to intervene in these babies who develop post-hemorrhagic hydrocephalus. But their observational data suggested that earlier intervention might lead to better outcomes and perhaps fewer permanent shunts. So she wondered if they created some clinical cutoffs, really clear definitions, could they actually prevent some of these longer term outcomes? So the results so far, that they had 97 babies. It took them, they had 127 babies. It took them 7 years, I think, to get all of these babies enrolled. They had 64 in the early intervention group and later intervention 62. And that what happened, of course, and what you would expect in the early intervention group, this was with ventricular index greater than the 97th percentile. AHW is anterior horn width. This is a measurement that you can do on ultrasound. And so they created these very clear definitions of when to intervene. And I don't know if you look around your unit and you see how maybe your babies are intervened at a very random pace too. Maybe it depends what neurosurgeon's on. Maybe it depends on what neurologist is on. Maybe it depends on what neo is on. So there's a lot of randomness. And so what they did is they created these really clear cutoffs. And they found that early intervention, probably not too surprisingly, had more LPs. So they would do up to 3 serial LPs and ended up having reservoirs at a higher incidence. But in the end, despite those earlier interventions, they ended up needing only 12 shunts. So about 1 in 5. So later intervention, waiting, they had lower LPs, lower reservoirs, but again, same, needing the shunt. And so it's still unclear, do those extra interventions and all of those pokes and things, in the end, does that result in long-term better outcomes? At this point, we don't know, we're waiting. So what we know is this is what happened. They had more LPs, they had more reservoirs, and they still needed 1 in 5 of them needed shunts. But if the long-term outcomes show that they're better, then it may be worth it. And so that's what we're waiting to see. We don't know yet. But at least someone's done the study and is looking, and has created some clear definitions for intervention. So we've talked about neuroassessment, we've talked about neuromonitoring, we've talked about neuroprotection. And so to wrap up, I'm just going to talk a little bit about neurodevelopment and the things that we can do to help that little mushroom of a brain turn into a cauliflower of a brain. And so whether we say we provide neurodevelopmental care in our unit, we are. And because babies' brains are developing so rapidly, every moment of every day, and every moment matters when we have this developing brain happening so rapidly. So when we think about neurodevelopment, we want to think about it in 2 ways. We want to think about it first about how do we help to grow new neurons, And so there are many ways that we can do this, some of them investigational still. So things like epogen, stem cell research, growth factors. But there are some things that we can do every day. There are things like massage. There are things like kangaroo care, optimizing nutrition. These are things we can do now to grow new neurons. And I love kangaroo care, and we probably all do. It's why we're here. Probably we believe in that. That's the natural environment of the human, and all mammals, is to be with their mothers and to provide that skin-to-skin contact. But what we also know, and this is a paper from Mark Scheer out of Rainbow Babies, almost 10 years old now, but it showed that babies who got skin-to-skin had higher Bayley scores. So remember way back when I talked about IQ scores and all of that? These are skin-to-skin. Babies who get skin-to-skin have higher scores on IQ scores and Bayley scores, which is basically a baby IQ score. They have better brain complexity. So their EEGs are more complex, and their brains on MRI are 2 to 4 weeks more mature than infants that don't receive skin-to-skin. It does something to the brain. It's neurogenic. So we love that. We want to help these brains to grow and to develop. So Jane Solomon is a nurse practitioner down at Tampa, and I was just talking to her last week, and she was talking about what in their unit, they've put a really big focus on the first hold, and they call it the First Hold Initiative. And I thought it was just an amazing thing that they're doing there, where they're basically planning and celebrating the first hold. So we all try to increase the number of minutes that our babies get kangaroo care, but I just love this idea of really marking the milestone of that first hold and trying to track in their unit when that first hold is happening. And so one of the things I mentioned in the beginning, the objective of this is all these things that we're talking about, these are all opportunities for you to do a QI project, to look at where you are now and to think about where you might want to go. So skin to skin, do you have a way in your unit to monitor the number of minutes a baby gets skin to skin for the first 2 weeks of life? Do you have a way to look at the whole cumulative effect? Like, how is your documentation? Is it just that mommy's held or that daddy's held? Is it how many minutes? We do these practices, but we're not always measuring them, and we're not always seeing, are there opportunities that we could do it better? And so for Jane and her team, the First Hold Initiative was something that they said, we are doing good with skin to skin. We are offering kangaroo, but we want to help that first hold happen sooner. And we want to celebrate it and mark it. And they take a picture of the mom when she's doing it. They put it on the wall. And then when the mom leaves, she can take it with her. But it inspires other parents as they come in. Nutrition. I love this picture of this baby. But we want to focus on nutrition. And Florence would say, let the food come at the right time and be taken away, eaten or uneaten at the right time. She knew that nutrition was important to health. We know that growth is brain. We know that optimal nutrition is neuroprotective. And that we also know that by using too many pumps and infusion of our breast milk, we're losing fat. And so I would encourage you to reconsider maybe going back to the old school way of only putting on feedings on pumps when it's medically necessary and minimizing the exposure of breast milk to plastic so that you're not losing that fat. And there's a couple citations here that you can look at that talk about the percentage of loss and things you can do to minimize that loss. So first, we're going to grow new neurons, and second, we're going to nurture the neurons we have. And I'm going to wrap up with a few of the ideas to do. We've all heard probably by now Mary Coughlin's trauma-informed care model. If you've not seen one of the previous webinars she did on toxic stress, we know that trauma is happening to babies, to parents, and even to us. And that we want to focus, of course, on the baby and the family, but we have to also recognize the stress on us. And that's a whole nother conversation. But to just be aware that this trauma is happening. And so what are the things that we can do to minimize trauma? Well, first off is minimizing stress and pain. We know that high levels of stress and high levels of pain can have actual anatomical and metabolic changes to the brain. We know this, and this is an elegant study that was done by the group in St. Louis that was looking at babies who had the A group. You can see there's this like red let me put my pointer up here and see if you can see it. So up here, the A group, excuse me, the A group are showing concordance, they're showing symmetry. These are controls, babies who did not experience a lot of stress. And so you want this symmetry of the brain firing. Here, you see that the B is a low stress group. So they had some stress, but you can see there's a difference. There's less concordance, less symmetry between these brains. And then look here at the babies in C level, they're having actually, you know, almost loss of neuronal function here and loss of that brain function in those areas. So decreased connectivity, structural, microstructure changes. So we're talking about in the beginning, like there's these things we can't see yet really with MRI. Well, these are some research techniques that are coming that might help to explain some of the longer term issues that we see with these babies. Maternal holding and painful experiences. There's a great Cochrane review that goes through what maternal holding, what skin to skin, what breastfeeding, how that impacts the painful experience. And so if you've not checked it out, I wanted to make sure that you knew it was here. Also, Marcia Campbell-Yo from IWK in Nova Scotia, she and her team have been working a lot on maternal holding during painful procedures, has some great YouTube videos on that. So I just encourage, if your unit's not maybe doing this yet, this might be something that could be an implementation opportunity. So minimizing stress, then supporting with therapeutic positioning. Being supportive, again, that comfort, that alignment. We want to make sure that we're not letting babies just lay all crooked in the bed. We want to make sure that we're putting them in that neutral position. If you haven't seen Mary Coughlin's great tool that allows you to assess infant positioning, I would encourage you to check that out. It's this APGAR score for the body. You can look at the shoulders, the head, the hips, the ankles, the feet, and you can actually assess them. So I love using this. This has been used several times in many hospitals to do a quality improvement audit of their developmental care and their positioning. I want to just reiterate that midline, we are oftentimes striving for midline, but this does not mean supine all of the time. We want to have that alignment of nose, nipples, knees, and toes, but we do not need babies to stay supine to stay midline. So I just want to make sure that I say that. We want to make sure that we're balancing sensory experiences, offering positive experiences, mostly from the environment, and we know that the environment is an undeniable impact on us, the ability to heal and in the environment. Florence talked a lot about that as well. And she would say that and I think the environment matters as much today as it did then. So what are some of the things we're doing for the environment? Private rooms, cycled lighting, minimizing noise and stress, right? In that 4 Bs that the girls in Knoxville did, minimizing noise, that position of where we place the babies. Maybe we put babies in private rooms. Maybe you still have them in open bays, but what are the things that we can minimize noise, but maximize language? We know one of the things that happens is we put babies in private rooms and they don't have a lot of visitation, that ends up being isolating to their sensory system. So we want to maximize language. One of my friends, Sarah Bakke from Nemours in Delaware, she created a baby bookworm program where for those babies whose families couldn't visit, they had high schoolers who came in and read to babies, read books. It's even better if you can have families do that, using a music therapist to help provide songs and stimulation. And babies do have a preference towards maternal voice and parental voices, but language exposure is important, and there is a food and language diet that we should be sure that we're providing. We do a lot of negative things, and we want to balance that with positive interaction. So if we do something negative to the mouth, we want to do something positive to the mouth. If we have to do painful procedures that are skin breaking, then we want to do something positive to provide containment and touch and massage, maybe skin to skin, to help balance out those sensory experiences. We want to be careful around how we move babies and try not to overstimulate them their vestibular system. Keeping them contained, offering 2-person care allows us to be more responsive and sensitive to those sensory overwhelm experiences. If any of you know me personally, you know I'm totally into aromatherapy, and I love to see that it's now being utilized in different NICUs, not only for families and to help families with their stress, but also babies like this infant with NAS who's having this little patch there on his, that little green hand that's next to him. And you can see that it has a little white disc and that there's one drop of an essential oil on there that's being then kind of locally diffused for him and showing already decrease in length of stay, decreased meds used, and decreased distress for these infants. So super cool way to offer that. We know we can offer maternal scent, that's always a soothing scent to all infants of all ages. But I like to see that we're, doing this for other more specific therapeutic reasons as well. We can't ever say enough about protecting sleep, and so I'm sure in your unit you're doing that. AEEG can be a tool that you can use to protect sleep. We always want to minimize parent-infant separation, and I love some of the tools that are now available, allow families to visualize their infant and to stay connected when they're not able to be at the bedside. And last but not least is really the psychological needs of our families. A lot of our families come in, they look pretty put together, but in the end and behind the scenes, they're a real hot mess. And these families need our support. These moms, these siblings, we need to address the mental health issues, the psychological needs of being in the nursery, not just for our babies' outcomes in the short term, but for our families. Because depression and anxiety, it's a huge common mental health issue. We know that treating mothers results in a better outcome for babies, better attachment, better temperament, better parent efficacy. So maternal mental health and just family mental health is not just fluff. It really is neuroprotective and part of the neurodevelopmental care we can provide. Dr. Shaw and Dr. Morea at Stanford, they have been providing this NICU psychologist team have been coming and they work with our high-risk families after they're referred by social workers. And they actually provide individual therapy sessions to our families. And this is a trend that more and more children's hospitals are doing. So really when we think about neuroprotection and neurodevelopment and changing our environment, these are the things we want to focus on. Minimizing stress, offering sensory experiences that are positive, protecting sleep, minimizing separation, and addressing these psychological needs so that we can also promote these strong bonds between families, because these bonds for these families need to last a lifetime. And we don't want to, we know that it's already an at-risk bond, and we want to make sure that we're maximizing that. So my final thoughts and the final thoughts from Florence is just never lose an opportunity of an urging and a practical beginning, and no matter how small. For it's wonderful often how such matters, the mustard seed germinates the root itself. So small things that you can do every day add up, and each of you have that opportunity to try something in your unit, measure something, see where you are, and then to go from there. So your 4 pillars are really ways that you can start, you can assess, you can monitor, you can protect, you can help the development of the baby's brain. And these each, as I hope you've seen, there's many opportunities for all of us in all these areas. So I thank you for coming. I thank those of you who watched the recording. And I think I'll just wrap up there, and that way we'll have a few minutes to maybe do some questions for those of you who are staying on.
Thanks, Kathi. That was really, I love all the practical tips you gave, not just the information, but ways that people can go back and make a difference right now in their NICU. Yes. So thanks for that different perspective.
For sure.
We're going to open up now for questions. If you run your cursor over the Zoom screen, you'll see at the bottom there's a Q&A tab at the bottom, and type your questions there, and Kathi will do her best to answer as many as she can.
Yep, happy to.
Can't believe maybe you did such a great job that no one even has any.
They're like, I'm overwhelmed with things I can do now. Not an unusual situation. Let's see. Can you speak to two-person care? Yeah, what is your specific question about it? So it's a trend, we hear people talking about this a lot. So let me help you. That's good. Yes, so slides, happy to PDF them and make them available. We'll send them out with the link to the recording, of course. So there isn't a lot of research done on two-person care that I'm familiar with. Maybe some of you who are in the audience are actually more aware of it than me. I think really what it speaks to, and two-person care doesn't have to be, you know, nurse and nurse or nurse and therapist. It can be parent and therapist, parent and two parents, right? It's really just helping. We know as we do care that we don't have enough hands, right? And so it's just being able to do what you need to do proficiently, but to be able to provide for the baby that extra support and containment. It's really about trying to provide, you know, less negative stress. And it's really there to, and I think it's an opportunity to engage families more, but there's not a lot of research that I've seen. But maybe someone's chatting something in, there's some. Yeah, oh, child life specialist. One of my best friends is a child life specialist. So sorry I didn't mention you specifically, but so what are the things that you can do as a child life specialist for babies who are cooling? You feel like you're very much hands off, no touching. What are some of the things that you could help to do? So of course your role as child life, you know, is there especially for teenage parents or if they're siblings, but I think anything you can do to help families with that time in which they maybe are hands off too. So if your hospital is not doing holding, I think anything you can do to help with just containment, helping to just provide boundaries. And then I think just what you do well in your role is to just talk about what the future might hold, and then helping families to just psychologically deal with that, maybe that separation, the transport situation. But no, your role is very important, and especially with siblings, I think your role really, really helps to describe, you know, what's happening. I hope that helped. I missed the name, but on child life. How can a unit that does not deal, so how does a unit that does not deal with neuro-infants still protect them? So Stephanie, this is a great question. So what I said in the beginning is that every NICU is a neuro-NICU. And so I don't know when you say neuro-infants if you mean specifically like cooling babies, but there are many opportunities. So all the kind of the 5 things I mentioned at the end, minimizing stress and pain. Any unit that takes care of babies can always be doing more there. You know, are you using sweeties appropriately or sucrose solutions? So are you using those appropriately? Are you minimizing the number of pokes? Are you, you know, all those things, pain, minimizing pain and stress. Sensory environment, are you looking at language and language development? So all those things at the end are all things I think that apply to every NICU, and even just our at-risk babies who are separated from their families because they're even getting, you know, phototherapy. You know, the separation is not normal. So anything we can do to minimize separation, help with parental anxiety and stress, even if the babies aren't that sick, doesn't mean that the parents don't perceive them as sick, and that is not very, very distressing to them. How are people holding cooling babies? So cooling babies, basically they're putting a pillow on the mom's lap, and then they're just picking up the baby on the actual cooling mattress and just allowing moms to hold, or dads, or grandparents in some hospitals. So it's just by just lifting them straight off of the, you know, using the blanket, and they're not allowing skin to skin contact, and then they're just continuing just as they are doing when the baby's in the bed to continue to monitor the core target temp and making sure that's not deviating. But yeah, you can bring the mattress around the baby a little bit more. Actually, I find that once they're being held, they actually do get better contact, and you'll actually see that the blanket actually warms up a little bit because they don't need as much to stay in their target temp range. So it's not an uncomfortable thing for families, but usually provides some barrier for them. You mentioned using aromatherapy for NAS. Are there suggested oils? So the oils that are being used in the research study are lavender and chamomile. And it's a blend, I believe, there in that picture I showed. And those are the ones that most units are using. Our unit is using a BrainZ monitor, which is an AEEG monitor. And can families still do skin to skin? Absolutely. So brain monitoring, so those electrodes being on the baby's skin, does not in any way keep them from doing skin to skin. What I usually do when I'm transferring a baby who has that on is I just unplug the electrodes. So be sure you label your electrodes at the end where you've plugged them in so you know which ones go in which holes. But just unplug that, mark an event that says you're transferring the baby, and then just bundle all the electrodes up and then transfer the baby to the mom. So do standing transfer is probably the easiest. Then you can kind of manage everything else and those probes. Get the mom settled. Then you can move the monitor around and pull that box back over and then plug the electrodes back in. But absolutely, there's no reason you can't hold and do brain monitoring. I mean, if you look at pediatric patients that are on full EEG, I mean, especially if they're on full EEG, they're wrapped up and they're glued on. I mean, those electrodes are not going anywhere. There's no contraindication to being held. I mean, small infants who have epilepsy and PICU, they're held all the time. So it's no worries. We have some resistance to containment during cooling. Can we provide boundaries as long as the temp doesn't increase? Absolutely. So you want to provide the containment underneath the baby. So you want to have the mattress still be in contact with the infant. So the mattress pad, you know, the cooling blanket part, you want to provide good contact to the baby. And then you just put the rolls around and underneath to provide that hip flexion, containment. But absolutely, what I find and what I mentioned was when you have better contact with the blanket, the blanket will adjust the temperature needed. It won't need to be, the blanket will not need to work so hard if the baby's having good contact. And so the actual water temperature might change, but your infant temperature will stay in that range. And so not to worry about that. And if the baby starts to get warm, the cooling blanket will go the other way, you know, so it will cool the baby. So let the blanket do the work and keep the baby in the target range. Do you have any suggestions on providing positive sensory experiences for preterm babies who are easily overstimulated? Music therapist, and I get consulted once they get near to their due dates, and at that point they've had such little positive sensory experience that they need a lot of help tolerating social engagement. Oh, such a good question. Well, I think as a music therapist, you're probably in the right position to be doing that. I guess I would say is maybe is there a way for you to be involved younger? I think most places are saying closer to 32 weeks that music therapy can begin to be beneficial to help regulate temperature. I was just in Chicago last week and heard a music therapist speak about this, and she did a really nice job of talking about some of the entrainment that happens, which is actually using the beat of the music to help slow down the heart rate and to help calm emotions. And so, so maybe it's just maybe reviewing the literature with your team and just showing some of the benefits of earlier integration of that service. And then of course, your role of maybe helping the families to do some of the parental voice recordings. So getting that language diet, some of that positive language diet started early could be ways that, you know, that can help support, can support that. But certainly, you know, babies who've had minimal stim in that isolation, then certainly it is startling for them. So I think it's what we're really trying to focus on now is that balance. And there are some units who are measuring the percentage of noxious talk and noise versus kind of that soothing talk, and using those tools to measure the percentage of that and then to change and intervene based on the percentage of each of those. But yes, huge. Having music therapists is such a, it's so much more than I ever knew. And so I've really enjoyed learning more about that role and your role. And I think it's really interesting. And I hope we're able to do it more and more and find ways that even without the therapist that you guys can consult us and help us. Let's see, there's a few more questions. Oh my gosh. So there's a question around nutrition and neuro needs. And I'm just going to say that there are a fair amount of research articles out there around nutrition, specifically maternal milk and neuro outcomes. And there's definitely out there. I mean, it's a really long conversation, I think, to have it. And the list of articles is really long. I just heard someone, I think her name was, I'm blanking, neonatologist in Boston, and she gave a talk. It was like an hour and a half long of just on neuroprotection and nutrition. Maybe you could email us when we send stuff out, and I could see if I can find some of those references. There were a ton. It was very interesting. But yeah, people are really looking at macronutrient content, and of course, breast milk for that as well. So it's too big of a topic, I think, to answer. So Stephanie Clark is asking again about aromatherapy. So there are units that are doing it outside of University of Kentucky who are doing it based on the fact that they believe that it doesn't cause harm. So there are some hospitals, St. Pete's in Florida. Oh gosh, I'm blanking. All kids in St. Petersburg. I know for sure they're doing it. There are other units here in California that are doing it. I'm using lavender, single oils, and 1 drop in the bed. So there are, Stephanie. So how early should you use sucrose to help with pain? 2 minutes prior. I believe that's what all the research says. So yes, Casey, you had asked about that. 2 minutes before the procedure. And that's a great thing to monitor in your unit. It's a great quality improvement project.
Super. I think we're done with the questions. Thank you so much. I mean, we had a lot of great questions. Thanks, Kath, for answering so many of them. I want to let people know that in order to receive your free CE, you are going to need to fill out the webinar evaluation. Please look in the chat area and you'll see a link to the evaluation. If you're watching the recording, please go back to the email you received with the link to the recording and click on the link to the evaluation form. Once you're done filling out the evaluation, you should, within 24 hours, but usually even sooner, you'll receive a PDF of your CE certificate. Be sure to check your spam if you don't receive the email within 24 hours. Lots of times it ends up in there. If you're watching live and you don't have time to fill out the evaluation right now, or your hospital has blocked access, you'll receive an email within a day or so with a link to the evaluation as well as a link to the recording. And just one final thing, if you're viewing as a group, you must each log into the evaluation form to get the CE. So we hope you will like Dandelion Medical on Facebook or LinkedIn and be the first to find out what's new at Dandelion Medical. We have 2 exciting new products coming out in 2019, and we would not want you to miss them. Most of the products in our portfolio were developed to support neurodevelopmental care. After you fill out the evaluation, you'll have an opportunity to sign up to get our electronic catalog so you can see all that we have to offer. So please visit Dandelion Medical website for future webinars, and also we have links to the recordings of our previous 3 years of webinars that are all still active and available for continuing education credits. We are so grateful for your participation. We have about 14,000 people on our Dandelion webinar list at this point, and we're thrilled to have so many people involved and active and wanting to learn the latest and greatest in what's going on in perinatal care. And we are so grateful to wonderful speakers like Kathi Randall, who have provided us with cutting edge education that really we hope is changing and improving the lives of premature and sick infants that are in the hospital. So thank you, Kathi, for everything that you've done, both in front of and behind the scenes for Dandelion. And thank you all for participating. And we'll see you in February for our next webinar.
Awesome. Thanks, Kath. And then I wanted to just make sure that I told everybody who's attended the webinar is that the one conference is coming up in February and that we have a special Dandy coupon code, which saves you $50 off of registration. So if you want to write that down, Dandy 50, That's really our special way of saying thank you to all of you who come to the webinars and who have supported them really from the beginning. And as a thank you for coming and listening to me, we would love to have you come where you can spend more time learning about that as well. So thank you all.
Super. Thanks a lot, Kath.
Yep. Talk to you guys later. Bye. Have a happy holiday.